Title: Multiple Myeloma Treatment. We would like to express our gratitude to our sponsor, First Cup Coffee, the original seed, for making this video possible. Shop firstcupcoffeeusa.com. First Cup Coffee, the original seed, is dedicated to providing high-quality coffee that fuels your studies and work with a rich and invigorating taste. We appreciate their support in bringing you valuable, free educational content. Remember to visit firstcupcoffeeusa.com for your daily dose of exceptional coffee. They also provide catering services for events and have a selection of fashionable clothing items for sale. Message them on Instagram at CoffeeFirstCup to receive generous discount codes. Introduction. Multiple myeloma epitomizes a quintessential example of neoplastic disease in humans, originating from a singular tumor stem cell and predominantly afflicting the bone marrow and bone. Its clinical spectrum encompasses bone pain, lytic lesions, fractures, anemia, and heightened susceptibility to infections, often precipitating symptomatic presentation at diagnosis, necessitating systemic therapy. While the standard first-line treatment for over 3 decades involved the alkylating agent melphalan combined with prednisone, MP, the past decade has ushered in a transformative era in treatment paradigms, propelled by the emergence of novel agents exhibiting significant clinical efficacy. Proteasome inhibitors and immunomodulatory analogs, IMiDs, have emerged as pivotal constituents of first-line therapy, particularly in synergistic combination regimens. Triplet regimens, integrating a proteasome inhibitor with an IMiD, typically lenalidomide, alongside dexamethasone, or doublet regimens featuring a proteasome inhibitor with dexamethasone, currently represent the zenith of efficacious treatment options. Bortezomib, initially sanctioned for relapsed or refractory multiple myeloma, has now assumed a central role in first-line therapy. Its mechanism of action entails inhibition of the 26S proteasome, thereby attenuating the nuclear factor kappa B, NF-kappa B, signaling pathway, pivotal in disease pathogenesis. Notably, the administration of bortezomib can be either intravenous or subcutaneous, endowing treatment with flexibility. Carfilzomib, an epoxyketone 26S proteasome inhibitor, holds particular significance for patients with multiple myeloma refractory to prior therapies, including bortezomib and an immunomodulatory agent. Its capacity to surmount bortezomib resistance, coupled with broad-spectrum activity spanning hematologic malignancies and solid tumors, underscores its clinical utility. Ixazomib, the latest proteasome inhibitor greenlit for multiple myeloma, distinguishes itself by oral administration with favorable bioavailability. However, it is linked with peripheral sensory neuropathy, gastrointestinal toxicity, thrombocytopenia, and hepatotoxicity. In essence, the landscape of multiple myeloma treatment has undergone a remarkable metamorphosis, characterized by the assimilation of novel agents wielding diverse mechanisms of action, heralding improved outcomes and expanded therapeutic avenues for patients grappling with this challenging disease. Multiple myeloma stands as a prototypical example of neoplastic disease in humans, originating from a single tumor stem cell and predominantly affecting the bone marrow and bone. Its clinical manifestations encompass bone pain, lytic lesions, fractures, anemia, and increased susceptibility to infections, often rendering patients symptomatic at the time of diagnosis, necessitating systemic therapy. While the alkylating agent melphalan combined with prednisone, MP, long served as the standard first-line treatment for over 3 decades, the past decade has witnessed a transformative shift in treatment paradigms, fueled by the emergence of novel agents with significant clinical efficacy. Proteasome inhibitors and immunomodulatory analogs, IMiDs, have emerged as pivotal components of first-line therapy, particularly in combination regimens. Triplet regimens, comprising a proteasome inhibitor plus an IMiD, typically lenalidomide, and dexamethasone, or doublet regimens of a proteasome inhibitor plus dexamethasone, currently represent the most efficacious treatment options. Bortezomib, initially approved for relapsed or refractory multiple myeloma, has now assumed a central role as first-line therapy. Its mechanism of action involves inhibition of the 26S proteasome, thereby downregulating the nuclear factor kappa B, NF-kappa B, signaling pathway, pivotal in the pathogenesis of the disease. Notably, bortezomib administration can be intravenous or subcutaneous, offering flexibility in delivery. carfilzomib, an epoxyketone 26S proteasome inhibitor, holds significance for patients with multiple myeloma refractory to prior therapies, including bortezomib and an immunomodulatory agent. Its ability to overcome bortezomib resistance, coupled with broad-spectrum activity across hematologic malignancies and solid tumors, underscores its clinical utility. Ixazomib, the latest proteasome inhibitor approved for multiple myeloma, distinguishes itself by oral administration with favorable bioavailability. However, it is associated with peripheral sensory neuropathy, gastrointestinal toxicity, thrombocytopenia, and hepatotoxicity. In essence, the landscape of multiple myeloma treatment has undergone a remarkable evolution, marked by the integration of novel agents with diverse mechanisms of action, paving the way for improved outcomes and enhanced therapeutic options for patients with this challenging disease. Thalidomide has firmly established itself as a therapeutic option for refractory or relapsed disease, with approximately 30% of patients showing a favorable response to this treatment. Combining thalidomide with dexamethasone has led to response rates nearing 65%. Lenalidomide and pomalidomide represent newer generation immunomodulatory analogs, IMiDs, derived from thalidomide. Initially approved in combination with dexamethasone for patients with multiple myeloma who have undergone at least one prior therapy, lenalidomide is now widely integrated into various combination regimens for first-line therapy. Pomalidomide, the most recent addition to the IMiD family, boasts the potential advantage of overcoming resistance to thalidomide and lenalidomide. While these IMiDs share similar side effect profiles, neurotoxicity is more commonly observed with thalidomide, less frequently with pomalidomide, and rarely with lenalidomide. Daratumumab, an IgG1 human monoclonal antibody targeting CD38, a cell surface glycoprotein highly expressed on multiple myeloma cells, has gained approval for both monotherapy and various combination regimens in patients who have undergone one or more prior therapies. For patients with relapsed or refractory multiple myeloma following 4 or more lines of therapy, idacaptogene viclucil, ITCEL, a CAR T-cell therapy targeting the B-cell maturation antigen, BCMA, on malignant plasma cells, has recently received approval. Although significant clinical activity has been demonstrated, ITCEL is associated with serious adverse events, including cytokine release syndrome, CRS, neurologic toxicities, prolonged cytopenias, and hemophagocytic lymphohistiocytosis/macrophage activation syndrome, HLH/MAS. Conclusion: thalidomide has firmly entrenched itself as a therapeutic cornerstone for refractory or relapsed disease, yielding a favorable response in approximately 30% of patients. Combining thalidomide with dexamethasone has augmented response rates to nearly 65%. Lenalidomide and pomalidomide, newer generation immunomodulatory analogs, IMiDs, derived from thalidomide, have extended treatment possibilities. Initially endorsed in combination with dexamethasone for relapsed or refractory multiple myeloma, lenalidomide has now permeated various combination regimens for first-line therapy. Pomalidomide, the latest IMiD entrant, harbors the potential to overcome resistance to thalidomide and lenalidomide. While these IMiDs share akin side effect profiles, thalidomide is more prone to neurotoxicity, with pomalidomide exhibiting this trait less frequently and lenalidomide rarely. Daratumumab, an IgG1 human monoclonal antibody targeting CD38, has garnered approval for both monotherapy and diverse combination regimens in patients with prior therapies. For those with relapsed or refractory multiple myeloma post 4 or more lines of therapy, idacaptogene viclucil, ITCEL, a CAR T-cell therapy targeting the B-cell maturation antigen, BCMA, has recently received approval, albeit with associated serious adverse events such as cytokine release syndrome, CRS, neurologic toxicities, prolonged cytopenias, and hemophagocytic lymphohistiocytosis/macrophage activation syndrome, HLH/MAS. Thank you for watching, and be sure to talk to your healthcare provider if you have any questions or concerns about your medications and any health conditions you may have. Disclaimer: the information presented in this video is for educational and informational purposes only. It is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you hear or see in this video.